Hello. Thank you very much for the invitation for the GI author interview. My name is Raymond E. Kim. I'm an associate professor of medicine at Division of Gastroenterology and Hepatology at the University of Maryland School of Medicine. The title of the paper that will be published in upcoming GI issue is Comparing Clinical Success and Procedural Difficulty between treatment-naive and treatment-refractory patients with esophageal motility disorders during the peroral endoscopic myotomy. I am the corresponding author. The authors from the first authors in order is Jagannath Kadiala, Andrew Kanakis, David Lee, Pesu, and Gregory Fan. So this paper is about the peroral endoscopic myotomy and the patients with the prior other treatment histories. Since the peroral endoscopic myotomy has been successfully used to treat patients with achalasia since 2008, still is a relatively recent introduction to clinical practice. A significant portion of the patients who will have had will undergo POEM will have had prior treatment histories, including Botox, pneumatic balloon dilation, or Heller myotomy. It is known that the prior treatment history is associated with fibrosis of esophageal mucosa, which may increase the difficulty of successive tunneling during the POEM procedure. As such, this study aimed to determine if the prior treatment methods were associated with longer procedure time, increased rate of failure, and or lower rates of symptomatic relief. The hypothesis was that the prior treatment would lead to an increased procedure time, but similar rate of clinical and technical success. So we reviewed the POEM, the patients underwent POEM retrospectively from like February 2017 to September 2021. We divided those patients in two groups, with a treatment refractory group who had treatment prior, and then there's the group with a treatment naive group. The results were basically, there were similarities and differences in between those groups. So the similarities that we found between the groups were the POEM was technically successful in both groups, 97% with the treatment refractory patients and 92% with the treatment naive patients. Average length of stay was also not different between two groups. However, there was also no statistically significant difference in adverse events between two groups, and there were no difference in the pre-operative Ecker score and post-operative Ecker score between two groups. The differences that we found, however, was the average case time for the treatment refractory patients was shorter, at 136 minutes versus 158 minutes of treatment naive patients. In univariate and multivariate analysis, both showed that the treatment refractory group had significantly lower case time, tunnel time, and myotomy time. Also, we found out that the prior treatment group had a higher preoperative distensively index on the endoflip. Further analyzing this procedural time differences, we standardized the procedural duration using underlying length, so the time per length measurements. But with this standardization, we found the difference wasn't there. So the tunneling time per length between the refractory group and treatment naive group was statistically not significant, and myotomy time per length for treatment refractory group and treatment naive group was statistically not significant. Also, the tunnel plus myotomy type was not statistically different. However, upon isolating tercile cutoffs for the tunneling TPL parameters, there was a correlation observed between the prior procedure history and upper tercile value. In other words, that the prior treatment procedural history were more likely to experience a tunneling time per length value less than 4.1 minutes. So the conclusion of our study was, as clinical outcomes were unaffected by procedural history, and the procedural themselves may be easier and faster, POEM remains an essential tool in the treatment of achalasia, especially patients who have had a failed prior treatments. Then what may have caused this shorter procedural time, including shorter tunneling time and myotomy time in the group with treatment refractory, may be explained in two ways. One is that we noticed that the prior treatment history group had more representation of type 1 achalasia. Generally, type 1 achalasia requires shorter myotomy lengths compared to spastic achalasia, so that shorter myotomy required type 1 case representation in treatment refractory group could have made this difference. The other thing is, but even then, we actually found that the isolation of the tertiary cutoff showed that tunneling, however, could be actually faster in treatment refractory group. This could be explained by the preoperative distensive index, which, in other words, the tightness of the lower esophageal sphincter was higher in the treatment refractory group. This may indicate that the prior treatment made the weaker lower esophageal sphincter compared to the treatment-naive group. Maybe that caused the faster tunneling time. So the prior treatment for achalasia, including Botox, pneumatic balloon dilation, and Heller myotomy, did not negatively impact clinical success or technical success of POEM. Instead, prior treatment was associated with a shorter procedure duration and decreased difficulty, which was likely due to decreased myotomy lengths required for type 1 achalasia and persistent LES changes. Treatment refractory patients with achalasia should be considered for POEM, and endoscopists should be aware of unique procedural differences given each patient's diagnostic indication. Further multi-center studies are necessary to better characterize the effects of prior treatment on LES and the long-term effects of POEM in these patient population. Thank you very much.